Hello, this is Emily Peters, recording Care of the Growing Family, Newborn Unit 5, Lecture 2. Okay, so one of the other aspects of care of a newborn is to do the APGAR assessment. The APGAR is used to evaluate the condition of the newborn at birth. I believe I mentioned one other time that it is done at 1 minute and at 5 minutes. This can be helpful in determining the severity of neonatal depression and may be predictive of neonatal survival. However, just to give you a heads up out there, there are some new studies saying that these APGAR scores may not give a good indication of that neonatal survival. You need to get a total score of 10. It is made up of 5 criteria, and you can get up to 2 points for each of the 5 criteria. And once again, you can get up to 10 points at 1 minute and at 5 minutes. The criteria we're looking at in the appearance is the A for APGAR. So are they pale blue? If they are, then they get 0 points. That pinky blue with some acrocyanosis, which is that the hands and the feet are just a little blue, you'd get 1 point, and then the body is pink, would get 2 points. So no signs of acrocyanosis. This is typically where kids won't get the full 10 points, is because they will be 2s for everything else, and then it's that acrocyanosis, which is not unusual. The P in APGAR is the pulse or the heart rate. Absent heart rate, of course, would be a 0. Less than 100 of a heart rate would be a 1, and then greater than 100 beats per minute for a heart rate would be a 2. The G is grimace or reflex irritability. Once again, you'd look at 0 for no reflex irritability or grimace. A grimace would be a 1, and a cry would be a 2. The A is the activity or that muscle tone. Is that baby flaccid and floppy? Then there would be a 0. If there's some flexion or slight flexion of those legs and arms, would be a 1. Active motion, so that baby's just kind of moving all over the place, then that would be a 2. R would be the respiratory effort. Apnea, no breathing. Irregular breathing would be a 1, and a good cry would be a 2. Okay. When we're looking at the score, we would ideally, all kiddos should be an 8 to 10. That means they're in really good condition. A score of 4 to 7 on those APGARs means that we need to do some sort of stimulation. And a score of less than 4 is resuscitation. Okay. Resuscitation meaning the full forms of resuscitation. Some people may even say resuscitation meaning stimulation. Okay, so full resuscitation would mean I'm doing probably putting some major oxygen on the kiddo and doing something along those lines. So this graph, which is in your book, kind of breaks down that scoring some more. So the different things. So once again, that heart rate needs to be done for 1 minute. So you're not going to do a 15-second heart rate and give them a score. That respiratory effort. Once again, you're going to want to do a good minute. That muscle tone, reflex irritability, the skin color. Now remember, if that kiddo has a really good cry, so we may end up doing like a really good cry and a strong, vigorous cry. That they might be able to do that respiratory effort and that reflex irritability at the same time, okay, and score that together. This graph is the Ballard assessment. This is also found in your book, and I can't place it right now in one of the appendices. The Ballard assessment gives you kind of a good estimate on the gestational age. So, for instance, we know by utero or by dates of the last menstrual period on approximately how old that baby might be. But we can be off a little bit with that. By doing this Ballard assessment and looking at these different types of physical things that are going on with that baby, that can give us an indicator on how mature that child is and give us another way of estimating their gestational age. Okay, so we're looking at like, I believe page 546-ish. This is very important because it's going to help us anticipate if this child's going to have any problems. So if we know this kiddo is probably a term baby, however, we are showing that somewhere neurologically with doing like the arm recoil or the scarf sign or something along those lines, that they are scoring way under, that could give us a sign that something developmentally could be wrong also. Okay. And this will also help confirm if we were kind of guessing on, you know, about where that baby is, like by last menstrual period, and confirming those dates as well. Okay. I will try to go over these a little bit better in class. So some other things we're doing when we're assessing that newborn for that gestational age estimation is that resting posture. Is there any flexion? So is that baby kind of tight up or are they floppy? That skin, is it very thin and transparent, or does it look like there's some thickness to it and we can only see a little bit of like the veins and vessels underneath? Lanugo, that fine hair covering the body. Is there lots of it? Is there none? That once again will tell us something. So for instance, if there's no lanugo, that could mean that kiddo is premature. Or if there is just a little bit of lanugo, that could be a sign that the kiddo is term. Okay. The sole, the creases. So like in this picture, if there's tons of creases, then that kiddo's term. If there's no creases, that kiddo could be premature. The breast tissue. So looking at those breast buds or those nipples, there should be tissue and there should be some ability to see the nipples and that little bit of tissue on the breast for that kiddo to be term. Now, my premature babies that I take care of on a regular basis, especially the severely premature, sometimes you can't even see the nipples to any breast tissue. And it could be concerning to parents, but you can just tell them that they just haven't been formed and kind of show them. You can sometimes see a slight color change. Ear form and cartilage distribution. So like those ears, the more they fold over and they stick, the more premature they are, so less cartilage. The baby's ears should be flappy and pop back up like yours and I's. Male genitalias. The testes in the presence of rugae gives us an indication of if the kiddo's premature or not. So if the testicles, when you're feeling for the dropping of the testicles, when you're feeling in there, if you can't feel them at all, that could be a sign that the kiddo's immature. Female genitalia, looking at the labia majora and minora, if you can see the clitoris and everything very prominently, and that labia majora minora is isn't very prominent and isn't covering that clitoris, that's a sign of immaturity. Vernix, that cheese, if there's lots of it versus if there's none, once again, this all gives us an indication of that prematurity or maturity rating. Excuse me. So here's a picture of the male genitalia. This is what a term baby should look like. Another thing we're looking at in that assessment is that age and weight and growth chart. This gives us a really good indication of where they're at and how did they grow in their nutrition while they were in utero and things like that. And some of this is hereditary as well. So we have small for gestational age, average for gestational age, or appropriate for gestational age, and large for gestational age. Some growth charts are in your Heil book, the big Essentials of Pediatric Nursing book. And table Appendix A, starting on page 1170 and going all the way through to page 1179. And now that goes from, there's different growth charts for the different age groups. So not only do you have the one that we would use for a newborn, but you would have the ones in there for like your teenager, your older child. Okay. Small for gestational age, they're below 10th percentile on that growth chart. Average is between the 10th and 90th, and large is above the 90th. And this kind of gives us an indicator of overall growth patterns, but also some things that we need to be aware of or concerned about when taking care of this child. So, like, as we know, large for gestational age, kiddos could have problems with glucose issues. So if I have a child that is born and they are hitting above the 90th percentile, and then also there were a child of a diabetic mother, it might give me an indicator that I need to really pay attention to signs and symptoms of hypoglycemia for this child. So here's an example of that growth chart as well that you will be able to see. These growth charts are used quite frequently at birth, couple weeks of age, and then they'll do them at each of their checkups throughout that first year of life. And then as they have all their annual exams and yearly exams after that, we'll do these growth charts. And then if we constantly have deviations and things from one extreme or the other, like constantly way below weight or something, that'll give us an indicator that we might need to be doing some more assessments and checking to see if something could be wrong. So some other things, general appearance. These kiddos have really large heads in comparison to the rest of their body. I want to say it's like around age 2 to 5. 2-ish is what I'm thinking. I'm blanking on this right now. That head is still significantly larger compared to the rest of their body. Their umbilicus should be at the center of the body. Their extremities are short. They should have some flexion. Those hands should be clenched, opening, closing type of thing. They should be very alert. Average weight, right around that 7-pounder. But as we know, they can be 5.5 to 8.8 pounds. They can lose up to 5 to 10% of their normal body weight, and that's due to meconium, that extracellular fluid they're going to lose because they're just naturally from being born. They're not getting a lot of food that first few days of life. But they should be regaining and be back at their birth weight by day 10. If they have a greater than that 10% fluid loss, or they're not gaining that weight back by day 10, they're going to need to do some further evaluation. Could we have signs of dehydration? What's their fluid intake like? Are they cold stressed or having some chilling and that's not allowing them to grow adequately? Average length, approximately 20 inches would be a good number, but range is 18 to 22. Head circumference is another good thing that we look at, and these all go on that growth chart. Average is 13 to 15 inches or 32 to 38 centimeters. That head circumference should be about 2 centimeters greater than their chest circumference. Their chest circumference should be 30 to 36, or about 12 to 14 inches. When we're measuring the head, we're going to place that measuring tape across that prominent part of the occiput, just above the eyebrows, and go around their head. When we're doing their chest, it's going to be to that lower edge of the scapula or across that nipple line. Temperature. So, of course, we're going to be doing frequent temperature checks on these babies. Very crucial part of our assessment, because this is going to give us an idea of this kiddo stabilizing or having problems. Their temperatures can drop very quickly from any kind of temperature change, from taking their clothes off to doing that bath. Okay. Their temperatures should stabilize and stay somewhat consistent within 8 to 10 hours after birth. Right after birth, and some protocols are going to be different depending on where you work, we need to be taking it at least every 30 minutes until we're stabilized for 2 hours. Okay, and stabilized is 36.5 to 37.5. just to give you a head, like my magic number, the number that I like to kind of sit with is like that 36.8 to 37.1, because then I know we're right in a good median for the kiddos I take care of. The best place to take temperatures on these babies is in that axillary area, so in their armpit. We're going to look at their skin color, look at their hands and their feet. Acrocyanosis is very normal that first few days of life. So we're going to have that little bit of bluing like it is shown in this picture here. Now don't forget, acrocyanosis could show up when this kiddo, after baths, when this kiddo over the next couple weeks of life, but it shouldn't be a consistent thing. But it will show up when the kiddo's a little cold, right after bath, things like that. So it won't be unusual to see some acrocyanosis after that first few days of life, but consistent acrocyanosis during that first couple days is okay. We don't want it consistent, like constantly after that. Assessment, some other things. The skin color. We may see mottling, which I don't think we have a good picture of that. Mottling is you will have it's almost like spider webs is the way I like to call it, or a lacy pattern on the skin, where you have some dilated blood vessels under the skin, and this is due to that fluctuation, and it can last for a few hours to weeks. I've seen some kiddos during those cold stress or when they get super cold not only have that acrocyanosis but that mottling show up. Harlequin, or the clown sign, is half their skin is very pale and half of it is red. This is a vasomotor disturbance. The vessels dilate on one side of the body and the other side constricts, and it can last up to 20 minutes. This is also sometimes seen as a reaction to some medications. Jaundice. This is that yellowing of the skin, very normal. It increases with bleeding, forceps use, hematomas, trauma at birth. Erythema toxium, that's like a newborn rash. You'll see it typically during that first 5 days of life. Pretty much all newborns have it, and there's no pattern. It's just kind of all over. Milia, or baby acne, so you see those little white spots typically on their nose. Sometimes you'll see a mother. That's just those exposed sebaceous glands. Don't do anything with it. Leave it alone. I know mommies and daddies like to pop it, just like our normal acne. We don't pop it. Leave it alone. Skin turgor. The best place to do the skin turgor is typically the abdomen or the chest, kind of right near the, right below like your scapulas. Vernix caseosa lubricates the skin. And then you can have forceps and vacuum marks if the baby was born with assistance. Some other things we might see, so some birthmarks is the stork bites, like in this picture, telangiectatic nevii, or stork barks, little red marks. Typically, you'll see them kind of on the back of the head. Some will have them kind of around their eyeball, like on their eyelids. It's just the concentration of immature blood vessels. They will increase and get a little bit redder with crying. They should be fade by age 2. Mongolian spots are these dark spots, typically on the buttocks or the back area, or lower back area, of people of Asian, I believe Hispanic and African American descent. They usually fade by 4 years of life, and they look like bruises. So whenever you see Mongolian spots on your babies, make sure you are charting that and passing it on. Because once again, if somebody doesn't know about it, it could be because it looks like a bruise, some people might think it could be like an injury or somebody's abusing the child. Nevus flammeus, or a port wine stain, that's that capillary angioma. It's very common on the face. Can be flat, purpley red, can be raised. It can be seen also with some cancers, if I remember correctly. We also want to look for structural malformations, body overgrowth, cancers, and things like that. What is it? Gorbachev from Russia. I believe has a port wine stain. So this is, the top picture is that stork bite. It's a pretty big stork bite. That Erythranium toxium is the newborn rash that is in the bottom picture here. So this right here is the newborn rash. And this here is a stork bite. This is a pretty severe stork bite. Usually it's just, you can see how they have the little dots underneath of it. Usually that's all you see, but this kid has a pretty nice sized one. Picture right here is some Mongolian spots. So you can kind of see, typically it's right here is where I've seen the Mongolian spots. But you can see, like, this one has one right here, some here, some here. But if you didn't know what this is, it looks like a bruise. I've heard of kiddos having them up here, some on their arm, you know, and other spots. So that's why it's very important that we're charting these and where we see them, because they do. They look like bruises. So if you wouldn't know it and you were just somebody observing this kiddo and not knowing their family, you may think this kiddo has been abused. This here is a port wine stain across the kiddo's chest, cheeks and her mouth. This may lighten as she gets bigger. It may not, and she may always have that redness on her skin. Also, during our assessment of that newborn, we're going to look at their head. Is there molding? What are those molding? What am I talking about? Well, we know we have the brain. We have all the different plates, right? Well, in our babies, they're not all all connected, and so there should be some spaces, and that allows for that head to grow, and also for that baby to fit through that canal, because they'll move. So we're looking for molding. Are those plates overlapping? Are they split, and there's quite a bit of space between the plates? Things like that. The fontanelles are also, so we have anterior, posterior fontanelles. We want to see, they should be soft, and they should be just kind of leveled. If they're really concaved, that could be a sign of dehydration. If they're bulging, that could be a sign of fluid overload or increased intracranial pressure. So we have that anterior fontanelle that closes around 18 months. 18 to 24 months. The average is about 18. The posterior fontanelle closes around 8 weeks, or approximately 8 weeks, but you could see it close as early as 6 weeks and as late as 12 weeks. This is a sign of cephalohematoma. The cephalohematoma is very common with birth. It's a collection of blood vessels between the cranial bone and the periosteal membrane from ruptured blood vessels. They can be unilateral, bilateral, things like that. And it's just due to that pressure of being delivered, a vacuum, forceps, things like that. They typically appear within a day of life, sometimes 2 to 3 days after birth. It does not cross the suture line, so it's typically on one side of the head or the other. Okay, it'll disappear slowly, typically about 3 to 6 weeks. Because it's an accumulation of broken down red blood vessels, this increases your risk for jaundice because extra red blood cells are being destroyed. Okay, so remember to always assess your newborn and be aware, okay, my kiddo has some other risk factors for jaundice, plus we have this cephalohematoma. Even Capets can do the same. I'm going to really follow his bilirubin levels. Caput seducium, I never pronounced this one correctly, is a localized soft spot on the scalp. This is present at birth. It's a result of that labor and vacuums. It does override the suture lines. It typically disappears within 12 hours to 2 days. You can have a caput that is hidden underneath of that cephalohematoma. Okay, So there's times where you may not know you have a caput anencephalhematoma. Here's just like a nice little visual. I'm breaking down what a caput is versus a cephalohematoma. I'm going to move it up a little bit. There you go. Here's another little visual. A caput. Okay, goes on. Cap goes across the suture lines. A cephalohematoma does not. This one disappears without treatment. No pathological significance. Typically, you don't need to worry about this one. Okay. Some other things we're looking at is those eyes. Face is not only eyes but the face. Is the face symmetrical? They can have paralysis during delivery due to forceps to rubbing against the vaginal canal. Typically, it's temporary. Eyes may be edematous for a day or so. All babies' eyes are typically a blue or blue-gray, and that color could change up to 3 months to a year later. Just to throw a little tidbit out here, I have a coworker who, at the hospital, whose little one's eyes didn't change till she was almost 2 years of age. So you could have some variance there. So we're looking at those eyes. Pearl, not perla. Pupils equal reactive to light. Tearless. They don't typically have tears until they're 2 months old. Am I having any conjunctival hemorrhage around the eyes? Strabismus, that cross-eyed, is very common, and it typically goes away by about 3 to 4 months. We can also have that doll's eyes. I don't know if many of you have had these dolls, but you move them around, and the eyes just kind of roll whichever way you move the baby's head. Sometimes the babies will do that, and that is common for the first 10 days of life. When looking with the eyes in the development, babies perceive faces, shape, and colors, but their eyesight is at 2400. So they can only focus to about 7.5 inches to their face. So literally it's almost that amount of space from when that baby's breastfeeding to where the mom's face is. So not very far. They have a blink reflex, and we always check that red reflex because babies can be born with cataracts. The nose. These babies, we sometimes don't have patent nares. So we do called choanal atresia. And that means they have a blockage between the nose and the pharynx. So we need to check the patency. So one way they do that is they'll close off one side of the nair and see if the baby kind of breathes. And then they'll close off the other side. Another way we sometimes check this, and this isn't the best way to do it, is when we're deep suctioning and we're putting like a suction tube down through their nose. And if we can't get it to cross, that could be a sign, or get it to go down, that could be a sign of blockage. The mouth, baby sneeze, sometimes cough, but not very often. When their lips are touched, they typically do that sucking reflex. Sometimes you'll see Epstein pearls on the plates and the gums, which are small white specks that disappear within a few weeks. No big deal. They can also have thrush. Okay. Taste and smell, they'll show a preference for mom's milk by approximately 5 days of life. We also want to look for the palate, is it intact? Ears. We check for the placement of the ears because if they're really low set, it could be a sign of chromosomal abnormality. One way we do that is I line my fingers up with the inner outer canthus and kind of make an imaginary line. And as those ears are above that line, then it's normal. They will follow sounds, and they prefer those high-pitched voices. And sometimes low-pitched, but they don't like that in-between. The cry should be strong, medium-pitched. A high shrilly cry is indicative of typically a neuro problem or like hypoglycemia. We also check their respiratory system. Remember, respirations should be between 30 and 60 a minute. They may have those brief periods of apnea of less than 15 seconds. Heart rate should be between 110 and 160, occasionally up to as high as 180. We always do apical pulses. We can feel brachial, femoral, and pedal pulses as well. We will check those, but we only count by apical. We can do blood pressures on these guys, better done by electronic device versus manual. Make sure it only covers 2/3 of the arm. You can do Doppler as well. The umbilical cord we're going to assess, there should always be one vein and 2 arteries. If there's only 1 artery and 1 vein, that could be a sign of renal and GI abnormalities. The genitals, I kind of talked about this when we were looking at our assessment. So this would be very normal genitals on both of these babies. Girls could have pseudomenses, meaning thick white mucus or slightly tinged with blood, and that's due to all those hormones that they got from the mom. Males, we want to look for structural deformities, hypospadias, opening of the foreskin is small, distended testes, hydrocele, things like that. We'll also look at their anus. Is it patent? Are we able to pass stool? If they can't, that could be signs of other abnormalities. In this picture, here, this little boy right here, this is the old school way of cleaning umbilical cords. And the blue dye is this alcohol and like antibiotic ointment they used to use to dry up the umbilical cord. We don't use that anymore. Once in a while, you'll see a few hospitals with that. Also, with the assessment of the newborn, we're looking at their extremities. Do they have polydactyly or syndactyly? Polydactyly, which would be webbing or extra fingers or toes. What is their muscle tone like? Do they have that Babinski's reflex? Brachial palsies or Herb Duchesne's. Brachial palsy is paralysis of the arm related to birth trauma. Herb Duchesne is the most common, and you'll have damage to that upper arm. Typically, it resolves on its own. We may have to do some range of motion or splinting. Sometimes if they have a collarbone fracture, you can see some issues as well. Neural behaviors. We're looking at their alertness, their posture, and that muscle tone and that cry. Tremors. If we see a tremor, we're going to try to rule out, is it neurological or is that hypoglycemia? Okay, which a lot of the times the tremors, the jitteriness is that hypoglycemia. Reflexes. We have the tonic neck reflex, fencer position. Like the picture above, the infant is supine, the head is turned to one side, the arm on that same side straightens and the other arm flexes. So if you were to turn that kiddo's head towards that flexed arm, that arm would straighten out and that arm that is straight right now will flex. The grasping reflex, babies typically all grasp your fingers. The startle reflex, when startled, the infant's arms and hands will straighten out and move outward. The legs will flex. Rooting is that looking for food when their mouth is touched. Sucking is they will suck as soon as something's put in their mouth. The Babinski, right, that's when you're like checking the neuro and you draw that upside down J on their foot. And the fanning of the toes is normal up until a few months of age, like 18 months. Trunk incurvation, when you stroke that spine, when that patient is prone, that pelvis will turn to that side that you stroked. The stepping reflex is with like they're stepping when their foot touches a hard surface, they'll lift it up. So this is an example of the grasping reflex, the moral or startle reflex, the rooting reflex, the stepping. So that foot popped up after it touched the heart surface. So if we would watch this in a video, This other foot that is down on touching the surface should pop up, and he'll release the other one kind of like he's walking.